So I next invite Dr. Poornachandra. He's a vitreoretina surgeon from Narayan Nethralaya. Doesn't need any introduction. He's well established into a lot of work in electrophysiology and genetics. In addition, he's a retina surgeon as well, taking care of all the fields involved in the retina. So Dr. Poornachandra, over to you for full field ERG, when to order and what to look for.
Okay, thank you so much, ma'am. I think Subhadra ma'am's talk has made my job really easy. You know the basics now. So this slide is, these aspects have already been covered. We stimulate the retina. There will be biochemical and ionic changes in the photoreceptors and RP, which generates electrical potential, which is recorded as an ERG. So I'll just, walk through various case scenarios where there is some uncertainty about what's happening, what is intended, and what is required. I'll start with the night vision problems. This was a 26-year-old male who presented with some night vision issues. The fundus was essentially normal. We did an OCT. OCT was also normal. So at this stage, we thought before going ERG, the first thing what we suspect, 26-year-old, everything is normal compliance. We suspect it to be malingering. So before labeling it as malingering, we thought we'll subject him to the ERG. That is what we did. So if you look at the fulfilled ERG test, so the dark colored response is almost like undetectable. That means the rods are not at all functioning. So though structurally the OCT, everything is looking normal, the ERG is telling a completely different story. The same thing is seen in the combined responses. Also, both the A wave and B waves are affected. The lighter blood responses are relatively okay. Of course, there is an delayed implicit time and amplitude reduction, but compared to the rod component, cone component is relatively better. So when 26-year-old male, night vision, when everything is, OCT is normal but ERG is showing abnormality, the first thing we suspect is vitamin A deficiency. So when we ordered vitamin A level, it was found to be less, 0.02, so as compared to the normal. So it is confirmed that it is vitamin A related night vision problem. But the next question is, why should a 26-year-old have vitamin A deficiency? So on general physical examination, he did appear malnourished, and on asking some leading question, he gave an history of dyspepsia, frequent stool and all that. He underwent extensive workup. In fact, he had to finally undergo an intestinal biopsy by gastrosurgeon, where it was proved to be he had an intestinal lipofuscinosis. So the ERG was repeated after 1 week, 1 month and 2 months of resuming vitamin A administration. We gave 1 lakh international units for 3 days, followed by 50,000 units for 2 weeks. But if you are not keen on giving injection, you can also give the 50,000 international units, like 25,000 BD for 1 month. That is also fine. So this is if you look at the dark colored responses, this is a presentation that there was undetectable rod response. Just within 1 week of supplementation, the B wave is almost coming to normal. After 2 months, so it's completely normal ERG. So if not for this ERG, this patient would have missed the diagnosis, would have labeled as malingering, and he had a life-threatening disease also, a malabsorption. All these things would have been missed if not for a simple ERG test. So then I'll just show some example where the retina is looking abnormal but patient is asymptomatic. So this is one such case. 28-year-old male came for a routine checkup, had a 6/6 and 6 vision. He had multiple flex-like deposit, but patient did not have any symptoms. He just came for a routine checkup. We did an OCT. Again, OCT is also normal. So we thought of, obviously, when you don't understand anything, next thing we do is ERG. His ERG was also completely normal. If you look at this, the fulfilled ERG was completely normal. So this is a case of benign fleck retina. So usually it's a familial case. Patients most of the times are asymptomatic. These patients can just be observed and followed up on maybe an yearly basis. One more patient, this is 36-year-old, similar looking fundus. You can see that this patient also has like this kind of a flex-like deposits, but less obvious as compared to the first patient. But this patient told, though the vision is normal, he told I have a night vision problem, I have delayed dark adaptation. So OCT was again normal. So when he did an ERG, if you carefully observe, again the dark adapted responses were undetectable. There's an interesting thing happening in the combined response. If you look at the A wave is coming here. The B wave is supposed to go like this, but it's getting terminated here itself. It's not even reaching the baseline. This is the classic electronegative ERG what we see. So this is basically a case of fundus albipunctatus, which is a form of congenitally stationary night blindness. So all this, where we see electronegative ERG, that means there is some inner retinal dysfunction. As Subhadra ma'am was telling, the B wave is mainly from the bipolar cells. Whatever that affects inner retina, maybe like a CRAO, ischemic CRVO, or juvenile retinoschisis, you will get electronegative ERG. Basically, you need to consider situations where the outer retina is normal but inner retina is affected. So this is like classic example, both similar looking fundus. The first fundus looks more abnormal, but the ERGs is telling something else. So this is what we believe. Some of us who practice electrophysiology, we always believe in one thing: whatever that appears structurally like something doesn't mean that it's functionally behaving the same thing. This is the best example for that. So again, one more normal looking retina with unexplained vision loss. 26-year-old, recently married, brought by husband because she was quite inattentive to the surroundings. No positive history. She was giving variable response whenever he checked her vision. Sometimes she used to do 660, sometimes she used to tell, I can't see anything. The fundus was normal and OCT was absolutely normal. I'm showing you all the cross section. You could not find anything abnormal in the OCT. Autofluorescence was again normal. So we suspected, obviously, recently married, maybe not happy with the thing and all that, maybe malingering. But we thought of doing an ERG before labeling her as malingering. So if you look at the dark adapted are completely normal, whereas light adapted responses are like flat. It's almost undetectable response. There is very residual flickering. So that means the entire cones in the retina are non-functional. Okay, so though the fundus is looking structurally normal. So this is a classic case of achromatopsia, which is a stationary form of cone dystrophy. Again, depending on the gene involved, sometimes some patients could progress, but most of the time it remains stationary, and they don't go to a degenerative stage where patient will develop blindness. So this is the kind of defects what we see in case of achromatopsia. I think Simar has one of the largest series of this achromatopsia, but our patient did not have even that kind of a change. So usually in classic achromatopsia, you will find this defect which resembles a photic retinopathy, but it is possible in some cases even that may not be present. Okay, so that's the last case. So this is very common. They have taken multiple opinion, but what's wrong with my eyes? So these kind of patients are very common when they go from one institute to another institute. So this was a 25-year-old male, night vision problem, no positive family history. Distance vision was quite okay. It was 6/9. The color vision was normal. Anterior segment was normal. So on pedigree charting, he was born out of a consanguineous marriage, had one more younger brother who was normal. So this is the fundus picture. So when I saw the fundus picture, I was very happy. Oh, okay, this is the classic Mizu phenomenon, what we get in some of the CSNB group of disorders. And patient is telling night vision problem. I'm okay. I'm done. I know the diagnosis. I thought it's a kind of congenital stationary night blindness. So obviously, I just wanted to do an ERG just for the sake of documentation. But autofluorescence also quite okay. Nothing much there. So OCT was also normal. OCT was normal. OCT showed some skytic changes in the perifoveolar region, which is, at least for my experience, I have not seen these kind of skytic changes in CSNB group of disorders with Mizu phenomenon. So this, maybe I thought, oh, okay, maybe this is not a CSNB. This could be a mild variant of juvenile retinoschisis. Some cases of juvenile retinoschisis also can, exhibit this Mizu-like reflex. So that's what I thought. But anyway, I thought I'm going to get an electronegative ERG. That is what I expected. But I was surprised when I saw the ERG. There was no electronegative response. And this was the rod response was undetectable. The combined responses were also, so grossly delayed, and amplitude was also decreased. And light adapted responses were also abnormal. So delayed implicit time and reduced amplitude. So for some reason, these two waves looked somewhat similar. I thought I had something in my mind. So sometimes these are the ISAVE protocols. In one of the slide, Subhadra ma'am mentioned that sometimes you may have to go to non-ISAVE standard ERG. That's what we did. So we did long and medium length cone full field ERG. So basically we use for long wavelength, we use the blue background to silence the short wavelength cones and stimulate the retina with a longer wavelength, orange light, to stimulate the long and medium wavelength cones. It did not show any response. It shows undetectable. When we stimulated the short cones, we did the opposite. There was an exaggerated response. So basically, this is a case of enhanced Descon syndrome. So we call it as enhanced Descon syndrome because during embryogenesis, the rods cones develop from a different arm. So the one arm lead to development of rods and short wavelength cones. Other one limb will lead to formation of medium and long wavelength. In this condition, the entire retina is filled with short wavelength cones. There are no rods. That's the reason for the night vision problems. So fundus sometimes can be normal, but sometimes you can have these kind of mesoreflex or skytic changes. To conclude, I would like to say electrophysiology is an important tool to aid diagnosis in various diseases. It should always be followed by clinical correlation. Never take ERG or any investigation in isolation. So, and additional genetic information in cases of dystrophies does help. So, thank you so much.
Thank you, Poorna. I think that was such a wonderful cases and day-to-day problems in the OPD.